All right, so let's talk about Chapter 18. So this chapter starts a little bit different than the other chapters. That we're going to work through a scenario, or two scenarios in the beginning, and then we are going to cover the information. Make sense? So, kill that. All right, so we're going to work through two scenarios at the beginning, so you can take notes, but this is more or less of kind of a discussion, and we're going to take care of these two patients, and then we're going to talk about the things that we learned, okay? Eventually this clicker will work, I hope. There we go. All right, so your EMT ambulance dispatched to an unknown medical problem at a private home. Dispatch tells you to advise them if the paramedic unit is needed, so you're not going to get a paramedic right off the bat. Okay? Here's we got 60-year-old male sitting at the table with his hand over his chest. He's pale and diaphoretic, and he looks scared. Okay? So that encompasses your general impression, right? So BSI, scene safety, BSI-wise, what are you going to wear? Gloves and eye protection, right? Number of patients is clearly 1, right? NOI at this point, okay? So generally, what do you think the body system that's involved? Cardiac, okay? I'm okay with that. So your NOI is cardiac. Do you think there's any reason to worry about spinal precautions? No. What are 2 or 3 questions you can ask to guarantee that? Have you fallen? What else? Another question. One more question. Any head, neck, or back pain? Okay? That just double checks the fact that you don't think there's any reason for this guy to have spinal precautions. Okay? Additional resources. Are you okay right now with your EMT ambulance taking care of him? Why not? Can you add ALS in a few seconds when you ask questions? Yes. Do you add ALS just because? No. So right now you're okay with it, right? Good answer. Okay? So you got your general impression. Your general impression in your skills station would sound something like, I got a 60s male, appears to be in the tripod position. He appears diaphoretic. He's not looking at me. I'm going to consider him to be sick. Okay? Level of consciousness, you would say, hey, sir, my name's Sean. I'm with Deer Park Ambulance. How can I help you? He would look up at you and say, I'm having some chest pain. Okay? You've got level of consciousness, which is alert, correct? You've got his chief complaint, which is chest pain. Okay? Is his airway open? Yes, because he's talking, right? Is it patent? Yes. So breathing, is he breathing? Yes, right? Would you consider it to be adequate or not? What do you want to know about it in order to determine if this is adequate or inadequate? So the quality, what else? The rate, what else? Is he conscious? So that's good. Does he have any cyanosis? No, so that's also good. I would call him adequate breathing. Okay? Would you give this guy oxygen? Probably, but you would want to know what before you do so? Saturation. Okay? Circulation, does he have a pulse? Yes, because he's alive, right? You know his skin CTC. Okay? Is there any bleeding that you can see? No. Okay? Would you consider this patient to be critical or non-critical? Non-critical right now. You just work through your scene size up in your primary assessment. It's done. Right? That's exactly how it's going to look when you're testing in those medical assessment and even trauma assessment skill stations. Okay? So we talked about. So you work on your OPQRST. Okay? Patient describes an acute onset of chest pain while sitting at a table. This happened about 15 minutes ago. Okay? He describes the pain as substernal, so behind his sternum. It radiates to his left jaw. It's about an 8 out of 10. And he is prescribed nitroglycerin, in which he's already taken one of his own that has not relieved the pain. Okay? Makes sense? Who's got good handwriting besides Gabriella? You did a good job. You don't have to do it again. All right, let me go to the board and put 1 through 5 up there. Okay? Why she does that, number 1, what's your possibility of differential diagnosis? MI, right? What's number 2? So I like CHF. Okay, go ahead and put CHF number 2. What about number 3? Okay, you could put AAA up there for number 3. What else? 2 more. Okay, so acid reflux. 1 more. Angina. Okay, I like that. So there's your 5 things. Okay? So here's your vitals. You got a heart rate of 118, a respiratory rate of 22. He's satting at 94%. He's got a blood pressure 98/60. So you go back up to your breathing. Is he adequate for sure? Yes. Right? That's adequate breathing. Well within normal limits. Says it's regular when it comes to quality. Do you need to give him oxygen? You do? Why not? 94 to 96% is your goal, right? If you're going to give him oxygen, let's say he says I'm having some shortness of breath, could you give him 2 or 3 liters? Absolutely. Does he need 15 liters non-breather? No. In fact, we're finding out if you do that, you're actually going to make his heart attack worse. Okay? What's that? Because the oxygen causes vasoconstriction, and there's already a clot in that artery. Right? That's the big side effect we forgot about oxygen. Okay? So, would you assume that the body system you're going to assess is cardiac? Yes. Okay? So, Libby, next to that list, I want to know the things that you're going to assess nice catch, to assess the cardiovascular system. What's one thing you're going to do? So, you already done it. So, we don't listen to heart tones, though, right? Could you listen to lung sounds? Yep, so lung sounds, put that up there. What else are you going to do to assess the cardiovascular system? Blair, what do you got? So sure, you can put them on a heart monitor, right? So you can put either EKG or ECG, however you want to put that. What's another one?
Could you check the circulation,
So circulation, motor, and sensation. Yeah. I like that. So throw CMS up there. CMS. What else? Say again? Which you know, right? So you've already assessed it, so keep that in your head. What else? So you could rule out JVD, okay? So throw JVD up there. You could do a FAST exam, okay? More the neurological than the cardiovascular, but I understand the reasoning. What else? Yeah, so do an actual cardiac assessment. Does it hurt when I push? Does it hurt when you move? Does it hurt when you breathe? Right? Which involves you having to palpate and auscultate and inspect, right? Bare the chest. Is there any bruises, anything like that? Could this have been a guy who plays adult league softball who took a softball to the chest a week ago? Maybe. You got to look and ask those questions, right? So that's your body assessment for your cardiac. Okay? So here's his past medical history. He has angina. He's also a diabetic. Okay? He takes insulin and nitro, and he has an allergy to opiates. Okay? So you look at your differential diagnosis list, and are we still okay with everything in that list? Because I sure am. Okay? So you ask a couple more questions, right? Because now you want to narrow your list down, so you start asking some questions. The angina has been getting worse and worse over the past 3 months. Okay? Gradually less relieved with rest. So when he gets that chest pain and he rests, it's taking longer and longer now for that pain to go away. Okay? He's had to use his nitroglycerin more and more every time he gets this chest pain. Okay? And today, the nitroglycerin is not relieving his chest pain. What are we pointing at on your differential diagnosis? What is he having? A massive heart attack. Right? Define angina. What is angina? Chest pain. Right? There's 2 sides to angina. There's stable angina and there's unstable angina. Stable angina is the guy that has angina who goes out and mows the lawn and gets chest pain. So he stops, he sits on the front porch, he pops the nitro, and it goes away. Stable angina means it comes on with exertion and goes away with rest and nitro. Okay? Unstable angina is it appears without exertion and it can't be treated with nitroglycerin. So it's just finding out that clot or that occlusion is getting bigger and bigger, which means it's taking more and more work for that heart to actually relax and cause less damage. Make sense? So would you call this guy stable or unstable? unstable angina. Okay? So what can you do for him? If you are going to transport him, yes? So at this point, would you consider ALS, Mr. Mahaffey? Absolutely, right? Now you can justify it. I think this guy's having an MI. Okay? Would you want your paramedic lights and sirens to your scene? Yes. Okay? Now is he a critical patient, Jordan? Absolutely. Right? So if he's a critical patient, what are some of the things you're going to do for him while either A, you wait for ALS, or B, you're going to throw him in your ambulance, you're going to meet ALS en route? What are you going to do for him? You're an EMT, do something. So position of comfort. What did you say, sorry? Recheck vitals every 5 minutes. So you're going to recheck vitals every 5 minutes. So you're going to find out when the last time you took nitro, because then you can talk about your second nitro. The only thing that's slightly concerning is the 98. If your protocol said 100, you couldn't give it. But if your protocol said 90, you could. You still have to call medical direction either way, right? So they might justify it depending on. What else can you do for him? Go ahead, Blair.
If your protocol said like 100, but you would call medical direction for whatever reason for another drug that you gave them that, and they said, hey, would you give nitro, would you or would you not because of your...
As long as he said to give it, absolutely. Okay? What else are you going to do for him? Why aspirin? He's not prescribed it. Right. So it's one, and this, aspirin's the one that everyone always forgets, right? Is it a cardiac patient? Yes. Is aspirin going to help him? Yes. The half-life of aspirin is like 36 hours, which means not only is it going to help them from now, but it's going to help them 72 hours later, right? Aspirin is the most beneficial drug you can give any cardiac patient. Far outweighs oxygen, far outweighs nitroglycerin, right? Aspirin by far is the best treatment for MIs. There's studies going on right now that say nitro doesn't even really do a whole lot unless it's an inferior MI, right? We'll talk about that just a little bit. But really, aspirin's your best choice. Ask your questions. Are you already on aspirin? Make sure they don't have any bleeding disorders, stuff like that. Mark off your indications and contraindications. But think about aspirin, okay? So you got aspirin. You gave him a nitro, right, as long as medical direction said. So you're going to position of comfort. You're going to rapid transport him. You're going to check his vitals every 5 minutes, right? Go ahead.
You have to have medical direction for aspirin?
You do. So make one phone call for everything you want to do. Make sense? Cassie, go ahead.
So, would you meet paramedics or would you wait for paramedics?
So it depends. Let's say we're sitting right here, right? If our paramedic was in the valley and I'm going to Sacred Heart and I have to have ALS, I'm going to wait, right? Does that make sense? But if my paramedic is a division and mission, I would probably drive towards them and meet them en route. It depends on where your ALS is coming from. If they're between you and your destination, then go meet them. If they're behind you or coming from a different direction, you might have to wait for them, right? So everywhere is a little bit different. What was your question?
Will they ever advise for aspirin on someone with asthma? Because
So,
has an allergy to...
yeah, so it would be medical direction's choice, right? It sounds like we asked this question because it seems like it's kind of a gray area. It sounds like there was a group in a test that was done with aspirin that had asthma that had a reaction. So therefore, it's placed as a contraindication. It's not an absolute contraindication like if they've already taken aspirin, right? It's on the, some protocol, I don't even think Spokane protocols even list it. It's a nationwide thing, so they're kind of encompassing. There must be a couple of states that say, not if you have aspirin. So you'd call and ask, right? Same thing goes for nitro. In this case, let's say my protocol said that, nitro was 100. I might mention that to the medical director, right? And be like, hey, so I want to give nitro. I understand his blood pressure is 100, or it's 98, but what are your thoughts on still giving him nitro, right? They say yes, then great. Still document their name. When you document that, you're going to say he was informed of his blood pressure was 98. The protocol said 100, but medical direction gave the order to give 0.4 units, and just back yourself up on that. Go ahead.
So if they have BP at 98, but they're prescribed a nitro,
Mm-hmm.
can you tell them not to take it? Or...
So that's the hard part, right, is they don't have the ability. We see this all the time where they don't know their own blood pressure. So what happens is a lot of our angina patients get chest pain, and then pop a nitro doesn't go away. They pop a second nitro, they get dizzy and pass out, and someone calls for them because they bottomed their own blood pressure, right? In this case, you probably, if he's like, well, I'm supposed to take nitro by chest pain, you say, look, I understand that. it would benefit your chest pain, but right now your blood pressure is low enough that we're concerned that it might cause some more damage. Let's hold off on that nitro. It's a really good question. What other questions? You guys are asking good ones. Nothing? So you get to the hospital for this guy, and you find out he's got a 95% occlusion of the circumflex artery. Okay? That's a pretty large occlusion, right? So like I said, he's having a pretty massive heart attack. Pretty easy. That's how assessments work. That's how differential diagnosis works. Make sense? So let's do one more. You want to erase that stuff, Libby, for me? So, rule of thumb, they use the word chest pain. AMI, MI are the same thing. AMI is just acute myocardial infarction, right? MI is just myocardial infarction. That needs to be number one in your differential diagnosis list. If they use the word chest pain, number one. Make sense? So here's the second scenario. Your EMT ambulance is dispatched to a 32-year-old male with chest pressure. He complains of shortness of breath and nausea with no previous cardiac history. Okay? So here's what you're presented with. It's a 32-year-old male sitting on the ground holding his right side of his chest, grimacing. He's he's obviously diaphoretic. Air outside's about 54 degrees and it's raining, and they've been playing flag football at a school. Make sense? So, BSI scene safe. What's your BSI? Gloves and goggles. NOI or MOI. Could this be a trauma? Could be. So let's say it's not, because we haven't talked about trauma, so you know I wouldn't do that to you. So what's your NOI? But NOI is broad, not specific, right? So what body system are we talking about with NOI? Cardiac. Okay, number of patients, just one, right? Additional resources, right now let's just leave you, okay? Worried about C-spine right off the bat. Could be, so now rule it out, right? Did you fall? Did you hit your head? Do you have any head, neck, or back pain? The answer is no's to all of them. Okay? So, need to worry about C-spine? Not really. General impression, I got a 32-year-old male. He's laying on the ground. He's holding the right-hand side of his chest. He appears to be sweaty. It is cold outside. I'd like to put him in my ambulance and assess him further in the ambulance. Okay? There's your general impression. Okay? Hi, sir. I'm Sean. I'm with Deer Park Ambulance. How can I help you? I got some chest pressure and what else did he say? Chest pressure, and I got some short of breath with some nausea. Okay, great. Does he have an open airway? Yes. Is it patent? Yes. Breathing, is it adequate? Appears to be, right? What's his chief complaint? I forgot that one, sorry. Chest pressure, right? Does he have circulation? You know skin CTC, correct? Any major bleeds that you can see? No. Do you want to give him oxygen? Maybe based on saturation. Okay? So we throw in the back of the ambulance because it's warmer and drier and more controlled. Make sense? Let's see here. So patient states he's had right-sided chest pain for 3 days. Okay? Sharp chest pain, about a 4 out of 10. It doesn't radiate. It gets worse with deep breaths. The pain became acutely worse while playing football. It hurts to breathe, and he feels sick. Okay? 5 things. Number 1 has to be what? MI. Right? But he's only 32-year-old. Can 32-year-old guys or gals have heart attacks? Yes. Can a 14-year-old? Yes. Can a 4-year-old? Yes. Right? Pediatrics is less common, but you can have cardiac issues in kids. I pronounced a 12-year-old dead on a high school track at 1 in the morning during a cross-country all-nighter, and he had a massive MI. 12 years old. Right? They can affect kids. Okay? What goes at number 2? What do you think? You got 4 other things. MI is the easy one. So be specific, though. What do you think? Okay, so we can throw pulled muscle up there. I heard someone say something else. AAA. What else? CHF. Say again? That's not a diagnosis. Okay, pneumothorax. In this case, we'll put pneumothorax and know it's either spontaneous or simple, because it could be trauma, right? You'll be able to narrow it down real quickly by lifting up a shirt, and then if there's no damage, then it's a spontaneous. What are you thinking? AAA's up there. Are you talking about a brain aneurysm? Are you talking about yeah, AAA's up there. We threw pneumothorax up there. What was the other one? We missed one. CHF was the other one. Okay? So that's what we got. So here's his vitals. 104 in regular, 18 in shallow, 112 over 74, 96% of room air. Doesn't need oxygen, but he's complaining of shortness of breath. So nasal cannula of 2 liters, right? Help him out. Make him feel like you're going to do something for him. Okay? So it says shallow, but he's still 18. He's conscious and alert. His stats are good. I really wouldn't call him inadequate. Why do you think his respiratory rate's shallow? Because he told you deep breaths cause pain. Okay? So you really want to watch these 2 numbers, okay, as you reassess. You want a paramedic at this point? No? Okay. Live with your choices. Would you consider me critical, yes or no? Okay, so no. So no past medical history, no family history of coronary artery disease, no illicit drug use, liar, or smoking, good health, and he's got good eating habits. Okay? Doesn't take any meds, doesn't have any drug allergies. Perfectly healthy 32-year-old guy. Okay? Denies getting hit. Okay? Also denies dizziness, weakness, abdominal pain, or syncopal episode, which basically means fainting. Okay? Any questions on that? Any other vitals you'd want at this point? Anything? Glucose, he's 124. Okay? That was one I was thinking of. Nice work. Okay? So justify it. But you didn't put it on your list. So you want to put pneumonia up there as number 6? You can have as many as you want. Why? Why pneumonia? Okay? And it's rainy and cold. What else? So it hurts to breathe deep and it's pressure. What else? You're missing one other red flag because you just diagnosed him with the right one. So, but you don't know his lung sounds yet. He is sweaty. What else? What else did he say? What did you say? Progressively work for how long he's been feeling bad. That's the red flag, right? I've been sick for 3 days. Now when I'm exercising, it gets worse. He's like naming all the things off that should put pneumonia on your list, right? So no JVD, no peripheral edema, so you can get rid of CHF for the most part, right? Lung sounds, he's clear on the left, but he's absent on the right base, okay? Not CHF, right? Because CHF would be both sides, correct? Probably not a pulled muscle, right? And if it was, if that's why you called 911, you don't deserve to go anyways. That's not true. That sounds horrible. But I was being serious. Skin's warm, diaphragmatic, normal color, no trauma noted, no pain with palpation to either anterior, lateral, or posterior rib cage. Okay? So probably not a AAA. Okay? Could you get rid of pneumothorax? Can you? He's got absent lung sounds, right? So you know it's not a traumatic one. It could be a spontaneous. Okay? So here's your vitals, 107, 16, 110, 70, 100%. Okay? So he's compensating pretty well. Okay? So you get him to a hospital, he's got right-sided pneumonia. Okay? Now let me ask you, if you're going to treat MI, in this case, would you give him nitro? What do you think? Because MI is on your list. What's that? Why not? Okay, so it's more on the right side. Can MI present with right-sided chest pain? Can, right? Did he have any of the big risk factors for heart attacks? No, right? So the nice thing is you have to call medical direction anyways. So even if you wanted to give it, you could call and be like, hey, so here's the deal. 32-year-old male, been feeling crappy for the last couple days. We just took his temperature. He's 101.9. He's got absent lung sounds on the right, but he is complaining of chest pain. We're trying to cover a basis. Do you want us to give nitro? Doc's going to go, nope, it's pneumonia. So while you're there, just ask, do you want us to give him aspirin? He's going to go, nope, it's pneumonia, right? So now either you're going to treat the pneumothorax or the pneumonia. The treatment's the same, right? Position of comfort. give him oxygen if he needs it, which in this case, he's going to really benefit from those 2 or 3 liters, okay? Keep him nice and comfortable, take him to a hospital, right? Do you need a paramedic for this? I probably wouldn't, right? Unless your agency says you have to have ALS on every single call, right? This would not be a call I would justify ALS on. Make sense? Any questions on those 2 scenarios? You're going to erase that and have a seat, Libby. Does that make sense how those 2 work together, differential diagnosis and assessments, right? Starting to kind of come together a little bit? Good, because you have to do scenarios here in like 2 hours. So hopefully that's coming together very quickly. All right, so let's talk about and review ourselves the anatomy and physiology of the heart, right? This is the stuff that you probably should kind of keep fresh in your mind. I would remember the path of blood travel through the heart, and I would remember the cardiac conduction system, okay? So this should still look pretty familiar, right? Blood comes in through the vena cavas, down into the right atrium, through the tricuspid valve into the right ventricle, out the pulmonary trunk that splits into the left and right pulmonary arteries, comes back in through the left and right pulmonary veins, dumps in the left atria, goes through the mitral valve in the left ventricle, pumps out the aortic valve, ends up in the aorta, and then at the top of that aortic arch, it feeds into the coronary arteries, right, as well as it branches off and heads up to the carotids, right, travels down the body, and I got a really good diagram here in a second I'll show you of the path of that aorta down to the body where it splits and so on, okay? The conduction system, remember, real basic in this class, but where does your conduction system originate? SA node that goes to the what? AV node, right? Then it travels down the bundle of His, which is right here, splits into the right and left bundle branches, and the bottom of that turns into the Purkinje fibers, which is going to stimulate those ventricles to fire. Remember all of this? Okay? You literally should be able to draw this. Okay? Makes sense? It's just a path of blood. Remember, your heart is a plumbing system and an electrical system that have to work together. Okay? That's the only review you get. Now we're going to talk about problems. Okay? That's it. We got lots of problems. Okay, so acute coronary syndrome, or ACS. ACS and COPD are pretty common in the fact that ACS is meant to be the broad term, just like COPD is. Make sense? So ACS takes care of everything that's affecting the heart. The NREMT is kind of poor when it comes to being uniform. Sometimes they use terms like cardiac compromise. Sometimes they'll use the term ACS. So know that those 2 terms are synonymous. Okay? Anytime the heart's not getting enough oxygen, we're talking about ACS. Make sense? Pretty straightforward, easy stuff. Let's make it harder. All ACS-like patients or signs or symptoms, you assume they're having an MI. Okay? If you put MI on your differential diagnosis list, can you ever truly remove it? No, right? Even a paramedic can't. You can have a paramedic who looks at a 12-lead EKG and says they're not showing any signs and symptoms of a heart attack, and they can still be having a heart attack. Okay? Our 12-lead, the way it's done, we're only looking at the front side, which includes the top and bottom, and a little bit of the lateral side. We miss all of the back side and all of the opposite lateral side. Okay? The only way to get those is if the paramedic will actually take the 12-lead and put the stickers on the patient's back and look at the back of the heart, which is not done very often. Okay? Because truly, your posterior MIs don't happen very often. Okay? Usually it's that left or right coronary artery that causes the big problems. Okay? So, chest pain by far is the best known symptom. Okay? Sometimes when you ask them, now, what does that pain feel like to you? Crushing, dull, heavy, or squeezing are usually pretty common when they, that's the quality, right? When they tell you the quality of the pain. Pick up on stuff like pressure or discomfort. these three words, pressure, discomfort, and pain, are the same thing to you. Okay? They say discomfort or pressure, just think of it along the lines of pain. Make sense? It's not uncommon for this to radiate along the arms, the jaw, or in the abdomen. Do not get caught up in if it's the left side or the right side. There is no statistical guarantee that it will be left side only. Okay? Just because they say it's in my right jaw doesn't mean it's any less of a chance it's going to be an MI than because they didn't say left side. Make sense? Doesn't matter the side. Okay, this is a pretty good look at all the places patients complain of pain and how they're kind of grouped together. Okay, this is nice because it's left of the sternum, right where their heart is. Okay, mid-chest, a lot of times they'll complain of the mid-chest up their jaw. Okay, down their arms and inside their armpits is also pretty common. Okay, this is the one that's kind of misleading because this one brings in a couple other differential diagnoses. This is a real common one for AAA. This is a real common one for appendicitis. This is also a real common one for gallstones. Okay? These are also just kind of just grouped together, right? This one right here, pain between the shoulder blades, this is common for cardiac as well as also very common for AAAs. Okay? Your aorta lies closer to your spinal cord than it does to your belly button. So when that thing starts to tear and dissect, a lot of times patients will complain of that back pain or between the shoulder pain. It's just getting referred somewhere else. Make sense? So difficulty breathing or dyspnea is also extremely common. They usually go hand in hand, right? Chest pain and difficulty breathing are really, really common to hear those two used together. Okay? In your female, geriatric, and diabetic populations, this might be the only symptom they tell you, okay? Which sucks because now you have to put any patient that says difficulty breathing, you have to put MI on your differential diagnosis list, okay? I'll say the three populations again, diabetics, geriatrics, and females, okay? I will tell you, especially if it's a geriatric female who's diabetic, it might present totally awkward, right? We had a lady present with right leg pain, and she was having an MI. Okay? Because of the diabetes, the way their neurological pathways are working are kind of totally messed up because of neuropathy, right? Because they're geriatric, because they're in that older population, their sense of pain is also decreased. So they may not perceive the pain, but they'll pick up on the fact their body's having some respiratory problems. Make sense? Other symptoms that are important, anxiety is a big one. Anytime you have a patient who says, I feel like I'm going to die, you probably should listen to them. Okay, I had a 72-year-old gentleman that we was from Colville to Spokane for a non-emergent interfacility transport, right? We've been talking the entire transport about his kids and all this stuff and where he'd been, and he was a vet and the different wards he'd been in and so on. And I was on the phone with the hospital, and I was talking about, vitals and all this stuff. And he the stretchers leaned back, so he looked back at me and said, hey, do me a favor. I said, what's that? He said, tell my wife that I love her. And I chuckled and said, we're going to be there in 5 minutes. You're going to tell her. And he went into cardiac arrest. Right? It was like, I have to call you back. Click. Right? Whatever fired in his head, that was the very first thing he could think of was, hey, make sure that you tell my wife I love her. Right? That's that impending doom. He felt like he was going to die. He just didn't use the words, I feel like I'm going to die. Right? They start telling you that, or you can see they're real anxious or they're real worried. Talk to them, right? It's amazing how much you're reassuring of, you're doing a really good job, your vitals are good, we're taking good care of you, we're going to get you to the hospital, we've got a paramedic coming who knows a little bit more than I do, maybe he can give you some medications that I can't give. Talk to them and try to lower that anxiety level, okay? Nausea and vomiting is also really, really common, okay? Also, the perception of, this is where we hear about like heartburn, right? Cardiac chest pain presents like the worst heartburn in your life. Okay, so some people are like, no big deal, it's just heartburn. No, there's a good chance this could be something a little more serious than just heartburn. Okay? Obviously, hopefully, these two at the bottom would key you into something wrong. Abnormal pulse, whether it's tachycardia, bradycardia, and of course abnormal blood pressure, should be a big red flag. Anytime you got a patient who's pale and diaphoretic, there's something shock going on, okay? This is one of the things that you can't control as a person. You can control your heart rate, right? If you hold your breath, you change your heart rate, which changes your blood pressure, correct? You can't mess with your skin color, temperature, and condition. So this is really your body's sign telling you on the outside that something is wrong. So pay attention. It's why skin CTC is so high up on our priority list when it comes to assessments, right? It's way up during the primary assessment. Pick up on those subtle signs and symptoms as soon as you can, okay? So patient assessment-wise, we basically are talking about this. You can do your primary assessment, no different. Get your OPQRST, get your sample, get your differential diagnosis list going, and then start asking additional questions to try to narrow those down, right? Ask about, more in-depth past medical history. Ask more in-depth about events leading up to this. Take some vitals. Maybe take some vitals that aren't taken very commonly, like temperature, end-tidal CO2, glucose, things along those lines. Make sense? Patient care-wise, most likely like sitting up, okay? Give them oxygen unless their saturations are between 94 and 96%, and think about the transport when it comes to ALS, okay? Can you fly a heart attack patient out by helicopter? Absolutely, right? Everyone always kind of thinks MedStar and helicopters are for traumas. We fly more medical patients out than we fly traumatic patients out, right? Because they're quicker, they're faster. That might be your only ALS in the area, right? People up in Republic and Northport, that's their nearest paramedic. So they utilize ALS or utilize MedStar or LifeFlight as that ALS. So one of the things that we quote-unquote can't teach you that we're going to teach you in this class is about how to hook up a heart monitor, okay? We're going to teach you about 3 leads, which people mistakenly call the 4 lead, okay? That's fine. When you get on with an agency, they may teach you how to hook up and do a 12 lead, okay? Your 12 lead is the best diagnostic when it comes to EKGs, okay? 4 lead basically just gives us a real basic look at your heart, allows us to look at the electrical pathways, allows us to kind of count out how long it's taking for electricity to cross your heart. 12 lead is the best one, okay? When you do a 3 lead, it will only print out a single strip, okay? You'll only basically get this bottom box, okay? This bottom box right here allows you and us to look. Do they have a P wave? Do they have a QRS? Do they have a T wave? We can count these and tell you heart rate. Each one of these boxes has an associated time with them and so on, okay? We don't teach you how to diagnose 4 leads and 12 leads. Be thankful for that, okay? Because it's brutal stuff. 12 leads prints out like you see here, okay? This gives you multiple looks using different leads or different stickers to take a look at the heart, okay? Some areas allow you to actually transmit your EKGs via Bluetooth to a hospital for a doctor to look at, read, and radio back to you and tell you what you're supposed to be seeing, okay, which is awesome, okay? We don't really use it here in Spokane County, but our paramedics are trained pretty well when it comes to diagnosing these in the field, okay? Now I want you to notice how there's a P wave, correct, the bump before the QRS complex, and then the QRS is the spike, okay, and then there's a T wave, which is the bump after the QRS. Okay, I'm going to go up here and use my fingers, a little easier. See how the ST segment, this piece right here, how it's nice and flat? There's a straight line that runs right here, correct? Everything goes back to that baseline. Make sense? Now the one on the left, what it's highlighting is what we call ST elevation. Okay? Notice how there is the T wave you're losing in this giant wide QRS complex. Does that make sense? Notice how it doesn't come back to the baseline and become a T wave, right? Because your S and T wave are actually elevated above everything else, okay? That's where you hear the term STEMI, S-T-E-M-I, which stands for ST elevated myocardial infarction, okay? These are big heart attacks. Okay? We joke and say that these are tombstone T waves. See how they're shaped? You's going to die. Right? We give aspirin, nitro. Paramedics can give morphine, and we drive like hell. Okay? Real fast. Or you're going to die. Okay? Or you can have permanent damage that we can't fix. Okay? The nice thing about 12 leads is we can actually, this is the same 12 lead as this, only it's blown up. We can actually know where on your heart that this damage is being done. The mnemonic we use is lie, lie, say all. Okay? Because we're simple-minded individuals. So this is a lateral lead. This is an inferior and an inferior lead. This is a lateral lead. This is an inferior lead. Septal meaning middle. Anterior, 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 lateral, lateral. So let's say there's a really weird ST elevation just right here on this one. In order for it to be a heart attack, it has to be in all the lateral leads, right? This one is really, really lowly elevated. And it's just because of where it ends up on the V6 is way over on the lateral side, right? So that's how we like double check ourselves. It's like, okay, so I saw ST elevation right there. Is it in all of my lateral leads? Yep, it's there. And then this tells us it's an anterior, which means it's in the front, and it's on the side. This heart attack, okay, is happening in the left coronary artery. Okay? You literally spend like 4 weeks in paramedic school diagnosing these, learning how to diagnose them. 8 hours, 3 days a week for 4 weeks in a row. Okay? And even then, that's not enough. Okay? We have a bridge course going right now for nurses to go to paramedic school in less time. Our medical director came in and lectured for 8 hours on 12 leads yesterday and taught them more than they learned in nursing school. The entire nursing school he taught more in 8 hours. Right? This stuff is brutal. This is one of the coolest things in EMS. If you can learn this stuff, it's awesome. Okay? Because it's amazing to look at it and be like, yep, you're having a heart attack, let's fix it. Okay? Or the paramedic looks, the guy's having chest pain, and the paramedic looks at this and goes, you know what, I don't think this is cardiac related. Let's treat them for something like pneumonia instead because I don't think they're having a heart attack. Make sense? That's what these give you that other machines don't. Okay? Go ahead, sir.
How much time did it take
Seconds.
to get to that diagnosis from?
Seconds. Yeah. So you put the stickers on, right? Just stickers. They hold nice and still. You hit acquire. Machine takes about 3 seconds. It prints out the strip. You look at the strip, and there's a process that is the only way to truly diagnose these is to do the exact same process every single time. And Joel teaches us a process that is, we don't look for the ST elevation right away because there's 50 other problems that could be wrong here. So first off, the way we're taught is there a P wave for every QRS, right? So we look, so P wave, P wave, P wave, P wave, P wave, yep. Is there a QRS for every P wave? So we do those. And then is it normally lengthened out? So you look at it and we're like, yep, it's normal. And then is it regular, right? So it's like, okay, beat, 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 yep, it's regular. And then we start looking, is there any ischemia, right? The ischemia is damage. So there's ST elevation in these leads, and there's depression. Notice how the ST elevation is flipped upside down in here, because it's looking at the opposite side. So on one side it shows up as elevation, the other leads will show it up as depression. And then we say, yep, it's a heart attack. So it probably takes us 30 seconds to a minute to diagnose one, right? The monitors, what I didn't show you here is the monitors will give you a diagnosis what they think it is. 80% of the time they're right? You're supposed to set like the parameters on the monitor, age, gender, and then hit acquire. Most of us don't. With this ST elevation right here, the monitor will diagnose with 3 asterisks. It will say acute MI and then 3 asterisks. If your monitor says that, it's a heart attack, right? So aspirin, nitro, oxygen if they need it, drive as quick to the hospital as you can get them. Make sense? So we talked about drugs on Tuesday, but here's your indications for nitroglycerin. We talked about this, right? Got to have chest pain. Has to be prescribed to them, which means they have a cardiac problem, right? Doctors don't just give out nitroglycerin because they want to, okay? They have to have it with them. That's kind of a dumb indication, in my opinion, because clearly, who cares? I have nitro. Do you have it? No. Great. Thanks for telling me. Make sense? So chest pain, prescription, history of. Okay? Don't try to learn a word. Break it down so you can memorize it easier. Whoops. Systolic blood pressure. Notice how it says meets protocol. Okay? Your NREMT wants to see you giving nitroglycerin anything over 90 systolic, not 100. Okay? Anything over 90. They have not taken any Viagra or similar drug for ED within 48 to 72 hours. And then medical direction has to say, yep, go ahead. For which part? I think Spokane County is 90. Because Deer Park falls under Spokane County protocols. I'm almost positive it's 90. I had to look it up to be sure. Okay? Here's your contraindications. Less than 90, just write that down and keep yourself from getting confused. So less than 90, they've taken an ED drug within the last 48 to 72 hours. This is also one of those questions, it's kind of like the, is there any chance you could be pregnant, right? If you ask this question in front of an audience, you may not get an honest answer. Make sense? So ask them in private. Okay? I've had patients once in my career where he said, any ED drugs? And he said, nope. And the wife walked out of the room and he pulled us in and said, hey, I got to tell you, and told us that he had been taking ED drugs. Right? It was like, you're right, he probably should have asked you in private. It was our, our apologies. Right? So ask them in private. So you can give them a repeat dose 5 minutes apart, as long as the pain didn't get better, their blood pressure is still stable, and medical direction says go ahead. Okay? You might make the mistake of calling medical direction and go, hey, can I give nitroglycerin? They go, yep. You say, great, click. And then in 5 minutes you want to get another one. You got to call back. Maybe ask the doc on the phone, would you authorize a second administration as long as blood pressure remains stable and their pain is remaining at whatever? Make sense? Kill two birds with one stone. Be on the phone only once, because sometimes it might take you 5 or 6 minutes to get a hold of a doc, right? You got to call the main line to the hospital that's an operator that puts you on hold to the nurse's station, who then puts you on hold again to get a hold of a doc who comes to the phone, okay? If this is a emergency, tell the nurse, right? Don't tell the operator. They can't control how quickly the nurse answers the phone. Nurse picks up the phone. You say, this is Sean with Deer Park Ambulance. I have an emergency question for a medical physician. They'll get you a doctor right now, right? If you just say, hey, I'd like to speak to a doc, it could be 5 or 6 minutes till they find a doctor and pull him over so you can talk to him on the phone. Make sense? Make sure they understand this is something pretty important. You're not calling just to be like, hey, bro, what's up? What's for dinner? So here's aspirin, chest pain, okay, shocking. Can't be allergic to it. We talked about the asthma. They're already not on any clot prevention drugs. No aspirin, no warfarin, no Coumadin. Okay? There are some new blood thinners out there that I don't know the names of that we're starting to see. So make sure you get a good med list, or at least ask them, hey, are you on any other antiplatelet or blood thinning medications? Okay? Have to be able to swallow. Medical directions got to say go ahead. It's pretty easy. Make sense? Contraindications, can't swallow, has an allergy to aspirin. They're already taking a medication that doesn't allow you to give it. They have asthma and doesn't allow it in your protocols, or medical direction says nope. So I don't know why it's not, that might be county to county. I know Spokane County is a precautionary if they've got ulcers, bleeding disorders, anemia, stuff like that. Keep that stuff in your mind, keep that stuff in mind, ask the questions. Like I said, follow your protocols. So this is just a look at the different arteries that feed the heart. Okay? Nothing crazy there. Let's take a quick break.